Continuing with respiratory failure, the concept of a vicious cycle is when you begin with your shortness of breath, it makes you anxious. That's a normal response. When you get anxious, you breathe faster. And when you breathe faster, your breathing muscles begin to tire. When your breathing muscles begin to tire, your shortness of breath increases, thus increasing your anxiety, and your breathing becomes even more rapid. Your breathing muscles get more tired, you panic. Eventually, your muscles are going to give out and you're going to stop breathing. Frequently, with shortness of breath, this is the end result. What we need to do is we need to break this vicious cycle for the patient so they don't panic or they don't wear out with their breathing and stop breathing. They have a feeling of impending doom. They say, I can't breathe. It's highly anxiety producing. Immediate nursing interventions. Reassure them, get their head of the bed up, get them sitting up, get a set of vital signs, a blood glucose. You want to do a focused assessment of the lungs and heart. Prepare and initiate oxygen therapy. Think about getting a blood gas. And if you're just on a regular med surg floor, at this point you might want to call the rapid response team for further support and assistance. Some of these things you're going to do simultaneously in real life. Treatment of acute respiratory failure, oxygen. And you're going to say, Mrs. Halk, but if this patient has COPD, really should I be giving them a lot of oxygen? In this state of distress, I don't care if you're a COPD or not, you get high flow oxygen, 100% non-rebreather, because we need to get your oxygen level up. Once we get it up, we can start backing down on the amount of oxygen we're giving you, but we need to get you through this crisis. Position of comfort, sitting up in the bed. Maybe they like to tripod, lean forward. We need to look at an ABG if it needs corrected. If they're in respiratory acidosis, maybe we could use BiPAP. Maybe we have to go straight for intubation. Do they have a combined acidosis? Do they need some IV sodium bicarb? What kind of medications are going to help us? Bronchodilators. If they're really short of breath, a meter dose inhaler is probably not the way to go. We want a nebulized aerosol treatment. And we would either use albuterol or a combination, duo-nebs, which is albuterol with ipratropium bromide together. That usually works better than just albuterol alone. And I'll let you look up what ipratropium bromide is and how that helps. Steroids, especially if we're talking with a case with inflammation, we're going to need to use steroids to decrease that inflammation, such as pneumonia or an exacerbation of COPD. Antibiotics, once again, do they have an infection? Do they have an pneumonia? So do they need antibiotic treatment? Basically, we have to treat the underlying cause. Remember in the beginning, I said respiratory failure is not a disease. It is a state of being. Think respiratory distress. So bad that you're worried your patient is going to stop breathing. So say we need to intubate the patient because their respiratory failure is so bad. So what kind of equipment do we need to gather in the room when we know our patient's getting intubated? The doctor's given the order, somebody's placed a call to the anesthesia department or whoever does it at your facility, and you know you need to gather some equipment. Well, you're going to need what we call an ambu bag or a BVM. So we need a mask and we need the bag. We need to hook it up to working oxygen on the wall. We need to make sure we have an oxygen source. How many times have you gone to use oxygen in a room and there's no, I don't know what a technical term for it, or we call it a Christmas tree, a green Christmas tree, to hook the tubing to. Make sure that that's there. Whoever's going to intubate may bring their artificial airway. Make sure you have suction. You have something to suction the airway out with, and that it's hooked to suction that is working, wall suction that is working and on. You want to make an anesthesiologist or a nurse anesthetist mad, hand them a yank hour, and not have the suction functioning or turned on. Have the respiratory therapist involved. After anesthesia is called, this is the next person that's called. They bring a ventilator. Either the person who's intubating will bring their own sedation or ask you to get sedation out of the Pyxis. Restraints. We don't restrain everybody right away, but you might want to have not necessarily wrist restraints, but soft mitts close by that if you need them, you have them available once the patient is intubated. We do not put restraints or mitts on prior to the patient being intubated. So when the provider is going to intubate, they're going to use a laryngoscope. This is a laryngoscope. It has a light on the end that shines in the airway, and they can see it. They're probably going to need an endotracheal tube between 7.5 and 8 size. They have a formula that they use based on the patient's weight to decide how big of a tube to use, but I can tell you that this is the average size tube that's used. A stylet that goes into the tube. It's a firm metal piece to help shape the endotracheal tube and sedation. Once they are there and getting their equipment ready, you need to pull the bed away from the wall so that somebody can step behind the head of the bed. Remove that headboard. These are things that you can do whether you're an ICU nurse or you're trained in this. You can just be a med-surg nurse. These are things that you need to remember to do. Pull the bed away from the wall so someone can step behind it. Pull the headboard off. When they're getting their equipment ready, make sure the patient is pulled to the top of the bed, and when they're ready, lie them flat. Don't ever lie somebody flat before they're actually ready to intubate. They're already short of breath and air hungry, and lying them flat is only going to make that worse. When the provider is getting into position, make sure you raise the level of the bed for that person that's comfortable. How high should the bed be for them so they don't have to bend over so far and hurt their back? Patient's head and neck put into a sniffing position, and we will watch this quick video of an intubation. So what they're going to use in this video is something, a video scope, that they can actually, it's called a glide scope, that they can actually visualize the airway on a screen with their laryngoscope. This is pretty slick, especially if the patient has a difficult airway. This works really well. So they're entering the patient's mouth. They're looking for vocal cords. They're nice little silvery gray strings on either side. There they are. Beautiful. That's what they want to aim for, right in between the vocal cords with the tube. And you can hear, I don't know if you can hear them or not in the video. They say take the stylet out. Once they think they're in, they'll take the stylet out and they'll inflate the cuff on the endotracheal tube with air, and then they'll check lung sounds for placement. All right. Just a picture depicting how it looks. Looking for those vocal cords. I'm not going to test you on different types of tubes. What we're going to be dealing with are oropharyngeal tubes. Nasotracheal tubes basically only exist pre-hospital anymore. So, as I was talking, after intubation, they visualize the tube going through the cords. They remove the stylet. They inflate the cuff with a 10 ml syringe of air. And we're immediately listening to both sides, the right, the left, and over the stomach. And you'd say, well, why over the stomach? Because if it wasn't, the vocal cords weren't visualized so blatantly clear like we saw in the video, we need to make sure that they didn't intubate the esophagus and the air is not going in the stomach, especially if you're not hearing lung sounds in the right and left side. Immediately, probably simultaneously while we're listening, we're putting a CO detector on the end of the tube. It's going to change colors, and it's going to tell us that we are exchanging oxygen and carbon dioxide. Also, tubes can be hooked up to the bedside monitor and get capnography waveforms to confirm placement. All of this is going to be documented by the person that inserted the tube. Once all these things are done, which is within a matter of a minute or two, the tube's secured with a tube holder. Everybody verifies the size and how far it was inserted. The person who inserted the tube, the respiratory therapist, and you are all going to chart in your own charting how big the tube was and at what cms it was inserted at the lip. We look at the centimeters at the lip, and we get a chest x-ray to get positive confirmation. Patients usually sedated. They got their sedation, and if they're going to stay intubated because they had respiratory failure, we need to correct their underlying issue. We aren't going to extubate them anytime soon. We need to keep them sedated. So, reassurance, you always talk to somebody. Even though they're not awake and alert, they can still hear. Some people remember people talking to them and things they say when they aren't on sedation and they're more awake and alert. So you want to make sure that the vent settings the respiratory therapist set are the ones the physician ordered. The respiratory therapist will check the cuff pressure to make sure that it is at the proper pressure. It's not too it's not too inflated, not underinflated. There's documentation that has to be done with all of these things. And then the nurse is going to place an oral gastric tube, not an NG tube. It's going to be a regular Salem Sump NG tube, but we're not going to put it in the nares. We're going to put it in the oral pharyngeal cavity. We're going to insert it that way. So our patient's intubated, the tube secured, placement was verified, x-ray was done, we got orders for sedation. So now we got to assess our breathing. Did this help the patient? Is their work of breathing improving? Once they've been intubated for 20 to 30 minutes, we need to do another ABG and see if we corrected the gas abnormality. They're going to get continuous pulse oximetry. We're going to listen to lung sounds, check chest expansion, make sure it's equal and bilateral. We're going to assess secretions. Sometimes before people are intubated, they can't cough anything up, but once we get them intubated, we can loosen that up and get those secretions out and see what they look like. Make sure the patient is comfortable. Not only should they be sedated, but they should have pain medicine. And of course, they're going to need vital signs. Some complications of intubation could be hemorrhage, subcutaneous emphysema, a pneumothorax, laryngeal nerve damage, right bronchus intubation, or tracheal erosion. Right bronchus intubation is we put the tube in too far and we just need to pull it back out a little bit. And how we know we would have that is that we would hear lung sounds on the right, not in the left.